Thank you for joining us today. We are pleased to have Dr. Jill Williams with us to present updates in the treatment of tobacco use disorder. If any of you has ever had the pleasure of attending any of Jill's live events, you will know that she's a very dynamic and extremely knowledgeable speaker on this subject. She is the medical director for New York City TCTTAC, as well as professor of psychiatry and director of the Division of Addiction Psychiatry at the Robert Wood Johnson Medical School in New Jersey. Dr. Williams is an expert in tobacco addiction and treatments and has conducted several biobehavioral, translational, and clinical trials for smoking in individuals with serious mental illness. She has extensive experience leading training sessions on tobacco treatment and designing organizational change models to promote smoking cessation at behavioral health agencies. So with that, I'm going to turn it over to Dr. Williams.
Thank you, Nancy, and good afternoon, everyone. It's very nice to be with you talking about updates in the treatment of tobacco use disorder. This is just my disclosure information. Our objectives for today are to kind of give an overview of several aspects of this problem, to understand the prevalence and consequences of tobacco use in populations with mental health conditions or substance use disorders, to really understand the biology of tobacco addiction, and then to learn a bit about interventions on the counseling side and in terms of medications that are helpful to treat tobacco use disorder. Obviously, we can't cover everything in an hour, but we'll try and give an overview. You may know already that tobacco use rates have been declining in the United States for several decades, but unfortunately it still remains the #1 cause of preventable death. Deaths attributed to tobacco outweigh almost every other cause you can think of, and tobacco is still responsible for about 30% of all cancer deaths. Smoke is toxic and affects nearly every organ of the human body. So in the risks from smoking picture, you can see not only the different cancers that are associated with tobacco use, but the broad range of medical conditions that are not cancer that are also linked to tobacco. So this saying, "It's the smoke that kills," really rings true. There's a lot of toxicity in cigarette smoke, and estimates are that cigarette smoke contains thousands of chemicals. The most current estimate is more than 7,000 different chemicals contained in the smoke from cigarettes. Most of these chemicals are toxic to the human body and includes a long laundry list of substances including acetone, cyanide, and carbon monoxide. Of these thousands of chemicals, at least 65 are known to cause cancer. So again, there's a tremendous amount of toxicity in the smoke. Remember that nicotine is only one of these 7,000 chemicals, and that nicotine is not responsible for the vast majority of illnesses that are linked to tobacco. Nicotine may in fact be one of the safest things, ironically, contained in cigarette smoke, although nicotine is responsible for the addiction. So just to say a bit more about these toxins and where they come from, nicotine is naturally occurring in the tobacco plant, but there's other chemicals and substances that come from the tobacco plant. One of the important ones is called nitrosamines, and it turns out that nitrosamines cause a lot of cancer. It's a potent carcinogen, and because it's in the tobacco plant, that helps us to understand that the risk for cancer is there in every different type of tobacco product you can think of, because the carcinogen is already in the plant. That applies to chew and pipes and cigars and every tobacco product you can think of. There are chemicals that are added during cigarette manufacturing, things that change the way tobacco smells or tastes or burns. We now have evidence that the industry has manipulated tobacco to even make it more addicting when people smoke. But most of the chemicals in fact come from when you light cigarettes on fire. When things burn in chemistry, lots of new chemicals are formed, and that's actually the source of many or most of the toxic chemicals in the smoke, and also includes things like carbon monoxide. So the toxicity by and large is in the smoke, although you can see there are other elements as well that contribute to that. Tobacco is associated not only with health consequences, but with a broad range of other negative consequences on people's lives. It's a barrier to recovery. It takes away all your money and causes financial hardships. It can be hard on relationships. It can make it harder to get a job or to find a place to live. There's now a lot of evidence that when people smoke cigarettes, they actually have worse mental health. And conversely, when they quit smoking, that they can actually have improvements in mental health. So the old myth that people needed to smoke or that it helps their mental illness may not really be true. There's now evidence that when people continue to smoke, they have more relapse back to drugs and alcohol if they're working on their recovery. There's the stigma of being a smoker, as well as the risk for fire, wrinkles, and numerous other things we can think about. As I mentioned, I'm going to focus in on some of the behavioral health outcomes. So there's now considerable evidence that when people quit smoking, their mental health improves. This is actually a large meta-analysis that combined the results from 26 different studies to look at the impact of quitting smoking on mental health. And the results from this study show that when people quit smoking, you can see that anxiety and depression go down, stress goes down, and quality of life and mood are better when people quit smoking. These studies often assess people for these changes somewhere between 6 weeks or 6 months after they quit smoking. That's an important comment because it also implies nobody feels better the first day. But in the long run, as people are successful in being able to overcome and stop using substances, we see many evidences of improvement in their behavioral health symptoms and measures and functioning. Similarly, to the way we would see that if they gave up other substances, alcohol, opiates, etc. When we think about who's left smoking in the United States nowadays, many populations have learned from these public health efforts that smoking is bad and bad for your health. And many people have quit over recent decades, but now there's evidence that smoking has become more concentrated in what we would call disadvantaged populations, those with lower socioeconomic status. And it doesn't matter how you measure that, whether it's low education, a lower income, but smoking is highly related to having low socioeconomic status. And then another group that also has disproportionately high amounts of cigarette smoking today are people who have a mental health or substance abuse problem. So by and large, nowadays, when you think about who smokes cigarettes in the U.S., it often falls into these two large population subgroups, the poor and the mentally ill. Certainly there are pockets of other populations that also smoke cigarettes, but those account for really two of the biggest demographic groups. This is an ad put out by a nonprofit organization called the Truth Campaign to try and dispel some myths and to alert the public about the impact of targeted marketing. For example, do people realize that there are more tobacco retailers near schools that are set in low-income neighborhoods more than in other areas? Again, suggesting the ongoing role of the tobacco industry in targeting vulnerable populations. This is a slide I often show because this was a front page news story in the USA Today newspaper a few years ago, and it was a story about mental health care in the United States and how we need to do a better job providing people with good mental health care. And it profiled this woman, Joan, and sort of told Joan's story Joan was a counselor working in the field, but Joan had had a tough life with dual diagnosis, experiencing both mental illness and addiction. And the story went that Joan had really done well in her recovery and overcome her illnesses. And during her battle, she learned coping skills that sustained her, helped her end her addiction, and helped her cope with her mental illness. And you can see from the picture, she's basically smoking a cigarette. And this was almost the caption under the picture in this national newspaper story about mental health. So again, sending a subtle message perhaps that this is recovery and this is how you recover from mental health. I would argue that we can do better than this, and that in many ways this is not really drug-free, and it continues a pattern of using drugs to cope. And so I thought it was sort of a striking example of some of our beliefs and maybe some of our hypocrisy as well in our systems. I do strongly believe that this is a drug, and so my orientation, my approach to this problem is not so much as a health condition or as a bad habit, but really primarily as a substance use disorder. Tobacco use is in the DSM-5 as a substance use disorder, and the reason is because biologically, although really in every domain, it meets the same criteria for substance use disorder as cocaine, heroin, and alcohol. So from your brain's perspective, nicotine activates the brain, activates the reward pathways really much in the same way as cocaine and heroin. So from your brain's perspective, this is a drug. In behavioral health systems, we don't often treat it like a drug or treat it the way we treat other substance use disorders, and maybe we would want to re-examine some of that. The other thing that's unique about this drug is that really the vast majority of people that use this drug of nicotine or tobacco are addicted to it. And when you think about that, that's very different than patterns, say, of alcohol use in this country, where millions and millions and millions of Americans use alcohol and only a few actually have an alcohol use disorder. Tobacco is different. There are not many casual users of the drug. Most people are addicted, and one of the reasons why is related to the delivery of the drug. That in fact, when you smoke a drug, it's really one of the most addicting ways to put drug into your body. When we think about defining those principles of addiction, a lot of it has to do with what's the biggest dose of drug that we can get to the brain the fastest. And when you can get a big dose of something to the brain fast, it tends to produce more reward and have more potential for abuse. And as you can imagine, smoking is really the fastest way to put a drug into your body, and is even faster than shooting a drug up into your vein IV, which we often think of as the worst or the most hardcore drug user. And in fact, smoking is slightly faster because delivery to the lung and then subsequently from the lung to the aorta and the brain is literally a shorter distance that the drug has to travel compared with if the drug is shot up into the vein, and you can see those are much faster than other ways of taking drugs like eating the drug or putting it up your nose. So some of the drug delivery and the smoking itself it sort of defines why this is such a challenging problem. In fact, when you think about nicotine, we don't think about nicotine as so addicting. Nicotine's available over the counter. Anyone can go and buy it without a prescription. But you see, when you smoke nicotine, it's very different what happens in the body compared to if it's delivered slowly through your skin. And so drug delivery is actually an important factor. So with this understanding that many or most people that you see will be addicted to tobacco, how do we do assessment then? It's not really useful if we just say everybody's addicted. And what becomes important then is understanding the degree of addiction. Do some people have mild addiction to nicotine, whereas some people have moderate or severe? And it turns out that there's one question that's very good for sorting this out. It's called the TTFC, which refers to time to first cigarette. Nicotine also has a short half-life, and it's gone from the body just a few hours after someone's last cigarette. So certainly when you go to bed at night, the cigarette smoker basically is losing all the nicotine in their body while they sleep, and they wake up every day of their life in drug withdrawal. The faster you pick up that cigarette and smoke it, the more heavily addicted you are. And so studies show that people that wake up and smoke in at least the first 30 minutes in the morning after they wake up are at least moderately nicotine dependent. In fact, if you smoke in the first 5 minutes of waking up in the morning, which many of our clients will tell us, that's an indicator of higher level or more severe addiction. And now studies have shown that, in fact, people wake up in the middle of the night. They don't even make it to the morning, which is an indicator, again, of a higher level of addiction, which has implications for treatment outcome. It's harder for people to quit if they're more addicted. There's a greater need for medication based on the high biologic levels of addiction, and it may even have implications for higher dose or greater treatment intensity to help those people to quit. So it's a very useful assessment tool, the TTFC, which gives us a lot of information about someone's level of dependence. If you're lucky enough to have a carbon monoxide meter, this is an additional aspect of assessment that can be very useful for a variety of reasons. Most people know what carbon monoxide is. They know that it's a poison, that it's a gas, that it comes from things that burn. What people don't understand is that it comes directly from cigarettes as well, because, again, they're burning. Carbon monoxide comes from anything that burns. And when carbon monoxide gets into the body, it has a negative effect. It actually pushes the oxygen off of the red blood cells, so it reduces the oxygen content that someone would have in their body. Over time, this puts a strain on your heart, reduces your oxygen content, makes you more likely to have heart attacks. So if you have one of these meters and you have a smoker blow into the meter, one of the uses of it is that you're able to give people immediate feedback. Sometimes people, especially if they're young or if they haven't had any kind of diseases or side effects from tobacco, they don't have as much motivation to try to quit because they don't see it hurting them. And this is a feedback tool that you're able to show the person a negative consequence, one way that smoking is hurting them today by reducing the oxygen in their body. So it is a tool to give people feedback in addition to doing your assessment. The other really powerful thing about carbon monoxide and about teaching people this message is that this is a completely reversible effect. So your body makes new red blood cells every 3 days. So if someone were to quit smoking, that carbon monoxide level that you're detecting in your office today would be close to zero in about 3 days of stopping smoking. So then it becomes a really important motivator for people. It's something that they're able to change. It's never too late to stop smoking. And it's a really useful way to give people feedback during treatment. We do it in group settings, and it has a variety of ways you could think about using it. But it's a very powerful biomarker, especially because it is reversible, and people like to see that go back to a normal level when they're able to stop smoking. So it's really a valuable clinical tool for doing this work. This is just some information about cost. They use a disposable cardboard or plastic mouthpiece. It's very easy to pick one up and use it. And again, it's documenting smoke exposure as a type of assessment. It allows you to confirm whether or not somebody quit because you can figure out who's a smoker versus a non-smoker based on their level. And it's an important motivating tool. Okay, so we talked a little bit about tobacco assessment, about some of the properties of smoke. I told you that nicotine has a short half-life. That means that when you smoke cigarettes or use this drug and you become dependent on it, your body reacts to the drug going away, which happens in just a few hours. So within just a few hours of your last cigarette, if you are a regular tobacco user, you can begin to experience some of the physical symptoms of withdrawal. And whenever somebody is experiencing withdrawal from any drug, it's actually a strong motivator that makes people want to use drugs. So if you want to make people use drugs, you put them in withdrawal, which I'm basically saying facetiously, because it makes people really want to seek out and get their drug to give them relief from these very uncomfortable symptoms. So the withdrawal syndrome from tobacco, again, happens just hours after your last cigarette. And as you can imagine, that causes a lot of people to relapse and go back to smoking when they're trying to quit, because it can continue for weeks after the time that they quit smoking, and can include sadness or depressed mood. It can include insomnia if they've tried to quit over several days. It can include irritability, anger and frustration, anxiety, trouble concentrating, restlessness, feeling hungry, and having cravings or urges to use the drug. This is a real drug withdrawal syndrome, and one of the difficulties is that the symptoms are not that specific. A lot of things that we treat in a behavioral health setting look like this, and so I think we often miss this diagnosis because we attribute these kinds of symptoms to depression or anxiety or other substance use disorders, and we miss the diagnosis of tobacco withdrawal. The other important point about this is sometimes people say that they want to stop smoking, but that they can't because they need to smoke to reduce their anxiety. So that seems to be a myth in the sense that there have been a lot of research studies to look at the role of nicotine and tobacco on anxiety and to try to prove that nicotine and tobacco reduce anxiety, and it's really never been shown. In fact, the research studies almost always show the opposite, that use of tobacco and that use of nicotine increase anxiety and may even cause panic attacks in some instances. So why would people feel that it helps their anxiety when the research shows the opposite? And the answer is, well, because of withdrawal. So if somebody didn't smoke a cigarette for a few hours, you would expect that they're having some of these symptoms, including feeling more anxiety. So what's the best way to make that go away? To smoke a cigarette. But in reality, smoking is not really helping their anxiety. It's just perpetuating this withdrawal syndrome, intoxication and withdrawal over and over again, which really over time is probably making the anxiety worse. So again, understanding the withdrawal is really important in clinical settings, helping to recognize the symptoms that maybe we've missed in the past, and also to explain some of this to patients so that they understand that there's really not much medical benefit, even in the mental health arena, that they get from smoking. Another aspect of doing this work which makes it challenging is that there is reduced access to treatment across the healthcare spectrum. I won't spend a lot of time on this, but there's evidence that, in all of behavioral health, we don't do so well in terms of getting access to care to the people that need it. And we know that it's worse for substance abuse still. And out of all the substances, it's the worst for tobacco. So it is still hard for people to receive access to adequate treatment in a lot of settings, underscoring the need for integrated models of doing tobacco treatment within the behavioral health care system. This was a recent study done by the CDC that looked at this on a national level. So nationally, how are we doing in behavioral health with addressing tobacco in both our mental health treatment facilities and our substance abuse treatment facilities? And sometimes we like to think we're doing better. Certainly I've been doing this work for 20 years. But a survey like this shows in many ways we're really not doing that much better than we were 20 years ago, because when you look at screening patients for tobacco use in mental health facilities across the country, you see that the rate is only 48.9. That means that we don't even ask about tobacco half of the time in mental health facilities. And that's a pretty poor indicator of doing tobacco work. You can see the numbers are even less than that for all the other interventions and are similarly low in substance abuse facilities. There's lots of models, though, for things that we can do, and the model I usually present is a model where everyone on the team does something. This is not something you need to have a specialty provider for. Everyone really plays a part, and in fact, if everyone is on the same page and promoting the same message across the treatment team, it's really going to help the treatments to be more effective. So I believe that there is a role for everyone in the spectrum and on the team with regard to this, because there's lots of brief interventions that people can use. This is just one model designed for primary care called 2 A's and an R that all providers at the very least can ask about tobacco, give people some brief advice about the condition, some feedback, and then refer them to treatment. Do you use tobacco? How much? What kind? How do you feel about quitting? And can I give your name to my colleague who's organizing some services? So even this brief intervention to acknowledge it as a problem, put it on the problem list, make a referral, talk about it in the open, is still an important step in the overall plan. And certainly we know that this treatment works. In many ways, it's not that different than other behavioral health treatment. Sometimes people say, well, I really don't know what to do, Dr. Williams. And I say, well, it's not really that different than treatment for depression or treatment for alcohol or other kinds of conditions we see every day. It's helpful to do brief assessment, and assessment can be therapeutic and not just administrative in giving people feedback about this condition and how it may be impacting them. Certainly, counseling and medications are where the evidence base is, so we know that counseling works. From evidence-based studies, we know medication works. It's probably best to do them in combination. These treatments are the most effective when we do them together. And I think it's helpful to have a context for thinking about this condition. And luckily, we have one in behavioral health settings, which is to really think about it and approach it like a co-occurring disorder. And I'll say some more about that. We're very familiar now with co-occurring treatment models in our systems, and they help us deal with challenging patients who have multiple problems, especially if they're not motivated for abstinence from substances. These are complex patients, and they often have worse outcomes if we're not able to address the complex nature and the substance use disorder. So these are people where we know that the treatment model says the more we can integrate the services, the better people will do. Kind of a one-stop shopping to whatever degree it's possible to do it, to provide services that are comprehensive but also match to people's motivational level. So this has the assumption that not everyone comes in the first day wanting abstinence. Not everybody wants to stop using cocaine and heroin. Not everyone wants to stop smoking. So what can we do in the meantime to continue to work with them? Well, the recommendations are that we take a long-term treatment perspective. Often it takes time for people to trust us and for them to change their motivation or reflect on their consequences. When nothing else is working, we can always do assessment. That's never the wrong answer in terms of engaging people and seeing them and having them come back. And it turns out some of the most effective strategies for these conditions include motivational interventions, the use of medications, and then we know that as much as possible, when we can include the bigger system of the case manager and the housing program into this overall approach for co-occurring disorders, we know that that's when people really do the best. It's interesting because when I look at this list, I feel like it has a lot of application for tobacco. We can think about tobacco this way, where we take a long-term approach and we begin to talk about it with every client, not just the ones who want to quit, and we begin to introduce some of these modalities and even talk about it in these wraparound services, and that it maybe begin to have more traction using this approach. As you can imagine, even especially with some of the things we learned today, it's pretty hard for any tobacco user to quit. It's a challenging addiction, and things like how many of your friends smoke and how much it's available in your environment are all factors that can make it even more difficult to smoke. So lots of people say that they want to quit, but unfortunately without treatment, we know that only about 5% succeed per year, which means about 95% of the people that try to just quit on their own without the aid of counseling and medication, 95 out of 100 of those people will likely relapse and go back to smoking. The success rates with treatment are higher than 5%, they're somewhere in the 25 to 50% range. You might say, well, that doesn't seem very high to only have a 25% success rate with stop smoking treatment, but I would argue that that's what it is. That's similar to outcomes with other substance use disorders, and in fact with other chronic diseases. In medicine, we don't have too many cures, and this is similar to other long-term chronic illnesses, and also is better than the option of not doing treatment. Why do people experience that it's so hard to quit? Well, there aren't that many treatment types available. There's only a few medications. Most people just get told by their primary care doc, go home and figure it out on your own. We don't make counseling as available as we could. Most of the counseling models that are available in the public health system are quite brief. Even if you've failed those 99 times, there's no levels of care or ways to access a more intense quitting experience, so that makes it challenging. And then we know that people don't even use the services that we have. Utilization is poor, or people use the treatments for too brief a time. They feel like they use the medicine for a week and they're done. And those kinds of strategies have lower success rates. So we can do a lot to enhance people's outcomes by really educating them about the need for treatment. You know, the things that lead to successful quitting are often characteristics that our patients are the opposite of. So people who are less addicted, have a higher socioeconomic status, who have no behavioral health comorbidity, and fewer friends that smoke, they all have an advantage in trying to quit smoking. It's easier for them. They're more likely to be successful. So we have to overcome some of these challenges, but one of the important predictors of quitting we can manipulate, which is the use of treatment. The more we can get people to use treatment and really adhere to treatment, perhaps use it for a longer period of time, that's one of the factors that we may be able to help people have a better outcome from. And as I alluded to already, the best outcomes are associated with people who use both medications and counseling simultaneously to try to stop smoking. These interventions are successful alone, but you increase the success rate 1.5 times when you provide them in combination. So that's really the message we want patients to hear. Not we want you to quit smoking, we want you to quit smoking with treatment, and specifically we want you to try to quit smoking with medication and counseling, which will give you the greatest chances of succeeding. In terms of the counseling approaches, I'm not going to say a lot because, in fact, people who work in behavioral health settings already have the skill set needed to provide these evidence-based counselings. The kind of counseling strategies that help people to quit smoking include skills training, relapse prevention, problem solving, coping skills, and stress management. And these are often the very same skills that people in our workforce already possess. So that's the good news in terms of mobilizing our workforce to help people change their beliefs about smoking, reinforcing non-smoking behavior, and avoiding high-risk situations. That a behavioral health workforce should be very capable at doing effective counseling to help people to quit smoking. You could do the counseling delivered in an individual session, one-on-one, or through group. They both seem to be effective. I'm sure everyone's heard of telephone counseling by now, which is terrific in many ways. All of our states now provide free telephone counseling services where you call up and you speak to an expert tobacco counselor who conducts an assessment and helps you set a quit date, and then there are some follow-up brief support calls. Overall, remember, it is a brief service, and it is targeting people who are in preparation, who are really ready to take a step to try to stop smoking in the next week or month. Often the feedback I get from people in behavioral health is, well, that doesn't describe my client, who's a little bit disorganized and ambivalent about quitting, and I'm not sure that they would trust this sort of stranger counselor. It's taken me a long time to develop a relationship with them. So this is a terrific service, and we should use it, but you can imagine that some clients could struggle with this kind of a service based on the way that it's set up and delivered. It is available in many languages, It is shown to work. I always say it's a great resource for staff or family or other people that are also working on tobacco, but there could be some issues that make it a little bit more challenging for people with serious mental illness. So I typically advocate that we're really the best people to help our patients to quit smoking if we're able to integrate that into our work. Support is another aspect of the behavioral plan that can be really helpful. The more support someone has, the more likely they are to succeed. And remember, if there's all smokers in your network, getting support then from non-tobacco users can be challenging. So it can be a useful exercise to think through the support plan with somebody. Who's going to help you when you're craving? Who's going to help when you're bored, or it's the middle of the night or the weekend? And how are you going to be able to access support and stay away from cues and triggers and remain tobacco-free? This is where internet resources can be useful, apps. I don't really think they take the place of treatment, but they can be a great addition to evidence-based treatment and provide additional support. I'm going to quickly now review some aspects of pharmacotherapy. Again, it's not an exhaustive review because we have limited time. But medications are the other big evidence-based treatment that we should be using for people and that are shown to work. The primary way these medications work is to reduce or eliminate the tobacco withdrawal symptoms, but the medications do other things, including they block the pleasure of smoking, so that can be a useful aspect of them. People are less likely to enjoy their cigarettes while they're using these medications. And the medications also lessen or delay some of the weight gain associated with quitting. These are the same medications that have been available for some time. There haven't been any recent innovations per se, but it includes 5 kinds of nicotine medications, and people refer to those as NRT, or nicotine replacement therapy, and then 2 medications that don't contain nicotine, bupropion, which is the same thing as Wellbutrin, and Varenicline, which is the same thing as Chantix. So people basically have 7 different options for medications that we can discuss with them in terms of the risks and benefits. And these are not experimental. All of these medicines are proven effective and increase the chances of quitting smoking 2 to 3 times compared to if somebody received a placebo. Briefly, the nicotine replacement is extremely safe and is available over the counter. The patch, the gum, and the lozenge, technically you don't need a doctor's prescription for, but with a prescription, patients with New York Medicaid can access it at no charge. So I would recommend you do prescribing for those medications to help people reduce the out-of-pocket fee associated with them. And we have information about that if you have questions. There are 2 other nicotine products I won't talk a lot about that also require prescription inhaler and nasal spray. But basically the rules about nicotine are more important than talking about the specific products. Most people don't understand nicotine's not really the problem that comes from smoking. People get diseases from cigarettes because of all the other chemicals in the cigarettes, not from the nicotine. So that nicotine is safe and really should be used, I want to say, almost aggressively, giving people a lot of nicotine replacement to replace the high levels that are in their body from smoking. When we give people adequate nicotine replacement, they're comfortable and they do a lot better and they have a much more successful quit attempt. So the rules about nicotine is to give people enough, use it all day long, not just when you're having craving. Use it for as long as you want. There's really not much evidence that it hurts people, and people could be taking it long term, at least in the realm of months, if not longer. You can give people nicotine medicine safely in combination with bupropion, and you can safely give people 2 nicotine medications together. There's virtually no risk in giving a cigarette smoker access to nicotine medication. So hopefully some of these myths are going away. I used to hear often psychiatrists wouldn't prescribe nicotine for patients because of the concern. But remember, you're not introducing a new substance when somebody's already been a smoker for 40 years. They're already used to having nicotine into their body, so there's very little risk. And in fact, it's a better alternative, safer than smoking, of course, because it's just a pure nicotine with all the toxins and carcinogens removed. Again, a prescriber that wouldn't be willing to prescribe it because of safety concerns doesn't match the idea that the government classifies it as an over-the-counter medication, because we, in fact, have decades of experience on the safety and efficacy of nicotine. I think that's getting better recently as well. The FDA is trying to respond to some of the ongoing concerns in the public and in the health community about this. So you may not know, but in 2013, there were specific labeling updates that the FDA issued. I think there's going to be some other ones coming out this year. But in 2013, the FDA gave updates about the use of NRT so that everyone would know that there are no safety concerns with using 2 nicotine products at the same time. It's safe to use the patch and the gum, and in fact, that's rapidly becoming a first-line approach. There's also no safety concerns really when people smoke on the patch, not according to me, according to the FDA. Some of those risks have been overstated, and again, we now have decades of experience with nicotine medication worldwide, which suggests that there's really not much risk in that practice. The last recommendation as of 2013 is that people can be on nicotine long-term if they want, that it's safe, and if it helps people not relapse back to smoking, that the risk-benefit ratio would be in support of that. I'm obviously not a cardiologist, and I could point you to references, but there are many, many articles written by cardiologists in cardiology journals which say that these medicines do not cause or worsen heart disease of any kind. So this is just a recent review in a cardiology journal that says these medications do not increase cardiovascular events. They can be used as rapidly as 2 weeks after a heart attack. And in some hospitals, people are starting them in the CCU to keep people from going out and smoking. There's no evidence of more cardiovascular events with bupropion or varenicline. So according to cardiologists, the risk of harm from these products is quite low. The risk from tobacco is actually quite high. And so the benefits of using these medications outweigh any potential low risk of serious adverse cardiovascular effects. So the risk-benefit ratio says that we should be using them to reduce the high death rates of cardiovascular disease in our patients. I'm going to skip through some of these unless people have questions, and then we can come back to the products. The patch is fairly straightforward. The oral forms of nicotine, the gum, the lozenge, and the inhaler all have in common that they're absorbed through the lining of the cheek. These products all essentially deliver a low dose of nicotine on a given use of the product. Even though the gum and the lozenge come in both a 4 milligram and a 2 milligram strength, we would recommend often using the 4 milligram strength because the absorption that you get from that 4 milligram lozenge or gum is only about 50%. So from the 4 milligram gum, you might actually deliver 2 milligrams of nicotine to the body, and that's basically the equivalent of a single cigarette. So when people say that they haven't been able to quit using the gum or the lozenge, and then you get a better history, it turns out that they only use 3 or 4 products a day. So if they're smoking 20 cigarettes a day, they might need 20 lozenges in a day to give themselves adequate nicotine replacement. And so many people you would find underuse them, didn't dose them enough, stop them after a short period of time. But when they're used in a more rigorous way, they're associated with better outcomes. The last thing just to know about these oral forms of nicotine is that absorption through the mouth is already pretty poor and gets worse if you take them with coffee soda or orange juice. So you have to give people education, how to use them correctly, how to let them dissolve slowly in the mouth or be chewed slowly, and to be advised not to use them with coffee or soda because acidic beverages will interfere with the nicotine absorption. So psychoeducation goes a long way in helping people to use these products effectively. And I'm going to skip these prescription products for now. What happens when people smoke at the same time that they're using nicotine replacement products? Well, the good news is that not much happens at all. People tend to not enjoy their cigarettes as much if they're also receiving nicotine through NRT. Over time, that might help populations to smoke less, and you could think of that in some ways as a harm reduction strategy. There's not really evidence that people have arrhythmias or serious cardiovascular events from that. The real symptoms of nicotine toxicity that people can experience from smoking on the patch are often limited to a little bit of nausea or dizziness. It's usually not worse than that, and rather than tell people to take the patch off, we could counsel them to not smoke a cigarette. You know, in the olden days, we used to run around and there would be a lot of hysteria about smoking on the patch, and we would often discontinue the treatment. And that's not really consistent with our current approaches for substance use disorder. A patient could really perceive that as being punished for relapsing and having their treatment taken away. And really the newer model suggests we want to keep people in treatment, engage them, keep them wearing the patch, understand why they're relapsing. Maybe they actually need more nicotine replacement, and trying to help them stay engaged in the process. Some studies have looked at the utilization of nicotine even in populations that don't want to quit. So what would happen if we just put patches on everybody, even if people said that they didn't want to quit? And about 7% end up quitting smoking over time. It's not a trivial number. It's not the highest success rate, certainly, associated with a medical intervention, but it's also not zero, and it does suggest some ability to try and engage people to use them and sort of see what happens, to see if they're able to smoke less, or if it ends up helping them to change their motivation about the process. In talking about bupropion, again, there's not really that many new updates. Bupropion works for tobacco cessation at a similar dose that we would use for depression. We typically start at 1 or 2 weeks before the time someone's going to try to stop smoking. It can have the same side effects as headache or insomnia. We try not to give it to people with a history of eating disorders or seizures because of the slightly higher risk of seizure. We don't know how it works to help people to quit smoking, but it does certainly seem to work, and there's some evidence that it may have activity at the nicotinic receptor as an antagonist, but nobody really knows still how it works. It works independent of depression, which means it could be a great choice for a depressed smoker in being able to use it for 2 indications, but it works just as well to help people to quit smoking in people who do not have depression. So it has an independent effect in helping people to quit smoking. It has an overall efficacy which is similar to nicotine replacement. So all the nicotine replacement products, or bupropion, if you said to me, how often do they work in helping people to quit smoking, I would say it's about 25%. That's 1 out of 4. Obviously, that means 3 out of 4 people were not able to quit with the medications. We wish outcomes were higher, but bupropion performs about equally well as nicotine replacement. One advantage, perhaps, with bupropion may be that it's associated with the least amount of weight gain compared to all of these treatments, and that may be an advantage for some people, or they may opt to take it for that reason. There's a lot of new work now in the use of combination NRT, giving people combinations of a long-acting nicotine product like a patch, adding a short-acting product like a gum, lozenge, or inhaler to help people, first of all, give them a higher dose of nicotine than they would receive from patch alone. It also provides craving relief because those immediate-acting products increase your nicotine delivery over about a 10-minute period, and that can help people with some immediate withdrawal and craving relief that they may not receive from the patch. And then I think there's kind of a psychological or behavioral aspect as well of using a combination that allows people to feel like they have a rescue medication, they have something they can do when they're in a high-risk situation. So for a whole bunch of reasons, it seems to be associated with higher success rates compared to if we gave people just 1 nicotine product. And most people are doing this almost as a first-line treatment now, starting with combination NRT, knowing that it is superior to giving people 1 nicotine product. So this is just from the clinical practice guideline to show you that there's a lot of evidence that 2 nicotine products essentially doubles your odds ratio of quitting compared to if you got 1. Patch and bupropion is also a combination that you can try for people, but you see the evidence is not as strong for the combination of patch and bupropion. The odds ratio is 1.3, only marginally better than either product alone, and the research has been mixed about whether or not that combination is better than either product alone. Whereas there's conclusive evidence at this point, I would say, that combination NRT 2 nicotine products is superior. And then the last treatment I'll talk about today is Varenicline. It has a completely different mechanism of action. It actually targets the nicotine receptor in the brain and has activity there as a partial agonist. The medication has no drug-drug interactions that we're aware of, and the main reason is because it doesn't interact with the liver at all. The body gets rid of it through the kidney, so that implies it's pretty safe with people's other psychiatric or medical medications. Again, development of Varenicline is based a bit on our understanding of the biology of addiction. In this part of the brain, the reward pathway, shown here is the ventral tegmental area and the nucleus accumbens, those parts of the brain become activated when we use addicting substances, including nicotine. This diagram is also showing that there are nicotine receptors in the ventral tegmental area, so when somebody smokes a cigarette and the nicotine passes into the brain, it turns those receptors on in the ventral tegmental area, causing activation of this pathway and essentially the release of dopamine in the nucleus accumbens. That's a really complicated way of saying people get pleasure from smoking like they get pleasure from other drugs. So Varenicline is essentially going to attach at this very same nicotine receptor, but it's not a full agonist. If it was a full agonist, it would likely be addicting. It has unique properties as a partial agonist that help people to quit smoking. So what does that mean? Well, as a partial agonist, it actually attaches to the receptor and it turns on the system, but to a much lesser degree. A very small amount of dopamine would be released in the system, not enough to cause higher addiction, maybe enough to cause well-being, or maybe enough to prevent anhedonia, or the lack of pleasure that people say they experience when they stop using addicting substances. By attaching at the receptor, the other way that Varenicline works is that it takes away or reduces tobacco withdrawal symptoms. It keeps you from going into withdrawal. It partially stimulates the receptor. And then the last thing it does is that Varenicline has greater affinity for the receptor than even nicotine. So it stays attached to the receptor, and if you're tempted to smoke a cigarette, then as that nicotine circulating around, it's no longer able to cause this pleasure response in the brain because Varenicline essentially blocks the receptor. So through this variety of mechanisms is how it's effective in helping people to quit smoking. It's been studied extensively, and in clinical trials, these are the real side effects that people can experience from Varenicline, more common than placebo, and they include nausea, insomnia, abnormal dreams, and then to a lesser degree constipation. Sometimes people report flatulence and vomiting, but those are much less common than nausea, insomnia, and abnormal dreams. You recommend that people take the medicine twice a day with food. When you take the medicine with food or after a meal, you have a greatly reduced incidence of nausea, and it's typically a twice-a-day dosing. This is a comparative study to show outcomes of a variety of trials. Basically, we're only looking here at the column for the odds ratio, so I can show you that Varenicline, in fact, has an odds ratio of 3. It's the only medicine that's uniquely better. Patch gum, inhaler, nasal spray, and bupropion, you see they all double the chances that you'll successfully quit compared to a placebo. They all work about the same, at the same rate in terms of overall effectiveness, but Varenicline actually has a higher success rate. It is associated with 3 times higher success in terms of the odds ratio, and in comparison to the numbers I gave you earlier, rather than having 25% percent of people successfully quit smoking from varenicline in a given study. The numbers are more like 35 to 40. People are often concerned about the potential for neuropsychiatric side effects, given that this has been reported. Interestingly, reports of neuropsychiatric side effects that people experienced almost always came from what's called clinical case data, somebody calling into a medical hotline or telling their doctor it happened to them. In research studies of more than 10,000 patients, where half of the patients receive a placebo, studies could never show that varenicline caused a higher risk for suicide, suicidal ideation, depression, irritability, or aggression. So there's been a lot of experience and studies with varenicline, which has now been out more than 10 years, and that it doesn't seem to be associated with these negative neuropsychiatric side effects, although it can cause sleep disturbance, insomnia, and abnormal dreams. At the time that this review was published in 2015, that was pretty convincing evidence that varenicline is not associated with neuropsychiatric side effects, but the FDA still felt that it was not enough evidence, and so they basically instructed the pharmaceutical companies of Pfizer and Glaxo to do this huge study to try and figure out once and for all if varenicline carried the risk for these neuropsychiatric side effects. This study is kind of famous now. It's referred to as the EAGLE study. Many of the results have now been published, at least 4 or 5 publications. And this is essentially the biggest smoking cessation study that was ever done. It included more than 8,000 patients and purposely included half of the patients had psychiatric illness. So to understand, are people with psychiatric illnesses more vulnerable to these side effects? We need to study them too. So let's do a big study and make sure half of the patients are stable outpatients with psychiatric conditions so we can understand if they're affected by varenicline. You can see here the psychiatric patients that were enrolled in the study had a variety of disorders, including depression and bipolar disorder, anxiety disorders, and there were some that had schizophrenia and psychotic disorders. This was an outpatient study. People took their medicine for 3 months. And it's called a triple dummy, which means everybody went home in the study every day, and they took 2 pills and a patch. But only one of the treatments was essentially active. So your patch might have been real nicotine, and your pills might have been 2 placebos. Or you might have gotten real varenicline, and the other 2 treatments were placebo. Or you might have gotten real bupropion, and the other 2 were placebo. That's what the triple dummy idea means. There was even a 4th group that got 3 placebos, so all the medicines were in fact fake or placebo. And that's really the only way, doing these blinded kinds of studies, that you can determine the true risk for these kinds of adverse events. So what did the study show? Well, the study showed, similar to other studies, that varenicline is the most effective treatment when given as a monotherapy. So the orangish sort of bars in this study show that the quit rates with varenicline are significantly higher in those people compared to the people that got either varenicline or the patch. You see varenicline in the patch also worked, but not as high success rate, bupropion or patch. They quit, but not as high success rates as varenicline, and all of those are higher than the purple bars, which means that they got no active meds, they got 3 placebos. And so that's basically the effect of counseling alone. So counseling alone works, but you see how the success rates go up with medication and how varenicline is the most effective. The reason this is shown 3 times on this slide is because all the way to the right is the overall sample of the 8,000 patients, and then the other 2 figures are each half of the sample with and without psychiatric illness. So to the far left, you see, when you look at people who have no psychiatric comorbidity at all, you see the same pattern, that varenicline is the most effective. But you see that overall as a group they have higher success rates compared to the middle figure, which shows the success rates in the psychiatric population. So our patients can quit, and they can quit using the same treatments, but their overall success rates on a given attempt are lower than people that don't have psychiatric comorbidity. But we can say conclusively, looking at this study, that even among psychiatric patients, varenicline is the most effective treatment, significantly better than if people got bupropion or nicotine patch. This study was really designed, however, to look at side effects. This was the primary outcome of the study. Did people have neuropsychiatric side effects? And it was a very comprehensive study. They looked at anything you could imagine. You see here, a long list of different kinds of mental health symptoms, aggressive behavior, just not feeling right. So they tracked almost anything you could imagine in terms of potential side effects. And what they found is that it didn't make any difference. So similar to all the previous research on varenicline, there was no evidence that varenicline was associated with more neuropsychiatric effects. This is showing the rate of neuropsychiatric effects in the 4,000 patients without psychiatric illness and the 4,000 patients with psychiatric illness. And the take-home or most important message is that there's no difference in the rate of adverse events, whether you got varenicline or bupropion or patch or even placebo. So it's not to say that they never happen, but you can't really attribute those symptoms that people report to varenicline because people are equally likely to say these symptoms even if they get 3 placebos. And that points out, that people are complicated, and some of the things that people attribute to the medicine could be tobacco withdrawal symptoms. It could be a lot of things, but it's not. It doesn't appear to be the varenicline. On the right side of the slide, you see that the overall rate among the psychiatric patients is higher than the non-psychiatric patients. But again, there's no difference between the medication subgroups. That is to say that people with depression come in during the study and they more often say, I was depressed this week. People with anxiety come in and they say, I had anxiety this week. Or people with schizophrenia say, I was hearing voices this week. So overall, they report more symptoms than people without psychiatric illness, but there's no difference between the medication groups. So based on this really important study, back in December 2016, the FDA essentially removed the black box warning. They said there's now compelling and overwhelming evidence that Chantix does not cause dangerous neuropsychiatric side effects. We have to stop perpetuating information that's not accurate, and in fact, the warning was removed from the product label. This is just some random information as we wrap up. Sometimes people say, well, Dr. Williams, my patients drink alcohol, and I'm worried about giving them varenicline. I still don't know if they'll have an adverse effect. And what's interesting is because varenicline targets the reward pathway in the brain, it at least has the theoretic potential to reduce other substance use as well. And there's now been more than 10 studies which show varenicline reduces alcohol intake. This has been shown in lab studies with rats, but also in a range of human studies in people who are either wanting to stop drinking or stop smoking. In a variety of clinical settings, varenicline seems to also have a positive impact on reducing the reward from drinking. So it's a very interesting finding. As you can imagine, varenicline would be safe to take even if you continue to smoke, and so there have also been studies of varenicline in populations that don't want to quit. This was a very successful study of 1,500 patients who said, well, I don't really want to stop smoking, but I'll try to cut down. And often that's what our patients say, that they're not willing to commit to abstinence, but they'd be willing to try something and to try to cut down. So in this study, people either got varenicline or they got a placebo for a 6-month period of time. They were given counseling support at different intervals and recommended, try to cut your smoking in half, and then if they were able to successfully do that, try and quit again, with the idea of sort of phasing out their smoking over a 3-month period. And what you see is that the group that got varenicline was very successful and very likely to be able to do that, to reduce their smoking to a point where they were able to quit and then remain quit months later. So reduction paradigms can be challenging. When you learn about addiction, one of the first things you learn is that people don't have control over their drug. So the idea that we send people home and now they have control and that they can use less is kind of a complicated idea. And you can see in the orange bars, when we just tell people to go home and reduce their smoking, they're often not that successful. Very few ultimately quit. But you see these paradigms where we think about reduction with medication to take away some of the withdrawal, to block some of the pleasure from smoking. They seem to be much more successful. So I think reduction can be an okay strategy and seems to even be more effective when used in combination with medication. So I know we jumped around and covered quite a few topics in this brief webinar, but just to conclude some of the ideas that we spoke about today, it is the smoke that kills. The smoke carries the greatest toxicity. We could think about approaching tobacco use as a co-occurring disorder, something that we all treat and that we try to talk about in every patient interaction. People who smoke in the first 30 minutes of waking up every morning are pretty addicted. They fall in the moderate to severe range, and they're probably a good candidate for medications. Studies suggest they would have, that kind of a person would have difficulty quitting without medication based on the biological level of addiction and withdrawal that they're likely to experience. Varenicline has superior efficacy when used alone as a monotherapy, but the combination of NRT may be equally good. So the field is starting to change and say we should really consider varenicline or combination NRT as our first-line strategies. Why not give people the best treatment first rather than make them have to fail to get the best treatment? So that's something that's changing and in process right now, and people are talking about in terms of considering those as the two first lines. And hopefully I've strengthened your skills and your confidence that you can provide this counseling. I believe you have many of the skills needed to do effective tobacco counseling, and you'll feel more able to do it in your work. I'm going to stop for a minute, and we can see if there's questions or if Nancy has additional announcements.
I guess as we're waiting for questions, I wonder if you'll tackle the question that seems to be coming up a lot in our system, which is why not give people e-cigarettes to quit?
Okay, so that's a complicated question. Most of medicine is nuanced. It's not a simple answer, and that's certainly true for e-cigarettes. So, you know, the e-cigarette idea is not a bad idea in the sense of providing people nicotine without the toxins of smoke. So conceptually it's not a bad idea, but the devil, of course, is always in the details. So some of my concerns about e-cigarettes is that they're not regulated, they're not tested, you don't know what's in them. There's a news report out today that somebody's e-liquid contained Viagra. So in terms of contamination or what chemicals are in e-cigarette and e-juice, again, there's no oversight or testing at all. So that's a concern in terms of you just don't know what you're putting into your body. Although overall, you could imagine the risk should be lower than cigarettes, but it is a little bit of a gamble if you don't really know what you're getting. So that's a concern. Another concern, certainly there's the big teen concern, although that's less relevant to our populations, but teen use is exploding, and no one really knows what to do about that and how that may impact teens in the future in terms of increasing their vulnerability to using not only tobacco but marijuana and other drugs. So that's an area where people have a lot of questions. And then finally, I would say, you know, there's a lot of overlap in vaping culture. People are using these devices for hash oil and other substances, and so I think in terms of protecting the milieu, I generally advise against bringing them into the treatment setting because of the potential to actually introduce a lot of other substances.
Thank you. Just to let folks know that our phone lines are unmuted if you have dialed in, and please also feel free to use the chat box. I don't know, Rusty or Noah, if you have some questions that you recall have come up in our conversations with programs that you'd like to share. maybe while we're waiting, I'm sorry I'm throwing out the controversial ones, but we've certainly been hearing from some prescribing clinicians that if the FDA removed the black box, why is Pfizer still listing some of these side effects on their commercials and other materials?
That's a question for me?
Well, it's probably a question for Pfizer, but what do you make of that?
Companies, on one hand, if anybody says it happened to them, like, okay, I took Chantix and I got freckles, and I make a formal report, and I don't mean to trivialize it, but, that's often in the package insert, too. There is some kind of anything that's ever been reported just for people's information. So there's that aspect that isn't going to go away just because of this study, because certainly people have reported this in the past, and that gets cataloged. I guess the difference is understanding that when it's been reported and cataloged, it doesn't prove causation. That information is interesting, but doesn't ever really prove that the treatment caused it. There's actually, again, overwhelming evidence that the treatment doesn't seem to cause it, but companies and the way the industry and the FDA, there's still some of this just reporting it happened, so I don't know if it's some of that. I'm not a wizard on the pharmaceutical industry, but I do know that Pfizer tends to be a more conservative pharmaceutical company, that they tend to take less risks in certain areas compared to other pharmaceutical companies, so it may just be their corporate culture. I just don't really know. It's probably a not satisfying answer.
I think it's important, though, to hear that distinction that they would list anything that was cataloged, and that's not necessarily based on a randomized controlled trial. That is much more convincing, like the one that you described here today.
Yeah, and that's done for every medication. That's the FDA's role, to sort of report and disseminate information, to be transparent. And so that information will sort of always be out there, even if it's been disproven.
Hi, Jill. This is Noah. I have a question, and this is something that has come up in some of our conversations that I think sometimes in the behavioral health field, prescribing clinicians, maybe other staff, don't necessarily feel like tobacco treatment is necessarily part of behavioral health care and belongs more in primary care. Could you kind of speak to that kind of conflict, as it were, that has sometimes come up around the reluctance to provide these kinds of NRTs and other treatments in behavioral health care settings?
Sure. So I think that there's a tradition. Certainly there's a tradition that we haven't always treated this problem. And so some of it is undoing some of that. And even when I trained to be a psychiatrist in the 90s, no one really told me to address tobacco in my work and in my patients. So, our systems haven't completely changed either to incorporate some of these changes in best practices. But I think some of where the change has, so tobacco work did essentially kind of grow up in primary care and public health, that those were the models and the treatment, the parts of the treatment system that really were on the forefront of saying, this is a horrible illness and people die and we have to do more. Behavioral health, frankly, is quite late to the game. Why is there now this shift then for us to do more? I think a few reasons. I think that first of all, we're going to get to the point where we're the only smokers left in the country, that so many people have essentially stopped smoking that the cohorts of people left smoking are our patients. So I would say that's sort of a good reason to get on board now, even if you never did in the past, because the need is overwhelming, and there's so much evidence it's the #1 cause of death in our patients. So that's probably what shifted in the last 20 years to make this issue be more resonant among our communities. But back to your original question, I also think there's kind of increased recognition and awareness of this as a drug addiction. you know, the people who were out there keeping the information down that this was not a drug addiction for 50 years was the tobacco industry. So they purposely never wanted people to talk about this as a drug addiction, and there's a lot of evidence in the tobacco industry documents of that. And really the first time that they even admitted at a congressional hearing that this was addiction was like 1995, which is pretty late in the game when you think about it, because so a lot of efforts publicly were to really to quiet that message. And now, since the tobacco settlement and the release of the documents and, you know, the proof that they knew it was addicting 100 years ago and that they tried to suppress that information, I mean, to me, that helps really underscore this is something that's in the DSM. You know, we're way better than primary care at treating all the other substance use disorders, so it makes sense to me that we would treat this as an extension of our other work, because we're in this business. So I think just reformulating it as what it is, and remember, a lot of those early messages were crafted by the industry.
Thank you.
Jill, if this is Rusty, just a quick question on, some people raise the idea that nicotine helps people with serious mental illness concentrate. So it helps with cognitive kind of issues. Could you talk to that?
Sure. Nicotine is a weak stimulant, and it basically acts in your brain at acetylcholine receptors. And acetylcholine is a very important neurotransmitter in our brains for a whole variety of functions, including attention, concentration, and memory. So the idea is nicotine then able to manipulate those systems to aid in our attention, concentration, and memory to mimic the natural activity of acetylcholine. And, you know, there's a little bit of evidence that that's true. So, for example, kids with attention deficit disorder really do seem to smoke more than other populations, and you can explain that at least in part because they're getting an attentional benefit. But the benefit that you truly get from nicotine is quite modest. It's not a great medication in terms of its ability to be a cognitive enhancer or enhance cognitive performance. It's been studied extensively for Alzheimer's disease and really doesn't seem to have clinical utility. There's a belief, especially among schizophrenia, where the literature is the strongest, that it may aid a bit in the cognition of schizophrenia. But even then, the evidence is frankly weak, and there's actually more evidence that shows that people with schizophrenia are cognitively a whole lot better a year after they stop smoking compared to when they were smoking. So it's not entirely clear, but there's a little bit of that theoretic rationale. I agree with you that nicotine could, in a small way, it's very modest, impact attention, concentration, and memory. So giving people the benefit of the doubt, again, there's not overwhelming evidence that that's true, but even if we believe it a little, then I would have no problem with people being on nicotine maintenance medication, because you're able to give people nicotine supplementation through NRT. And so if we really believe that people benefit from that, or you have a unique case where you're convinced somebody's benefiting, then I would be completely supportive of giving that person full and free access to nicotine like it's a medication. I don't think there's anything wrong with that. And you're lucky that you're in a state, New York, where you know, the supply is going to be ongoing. In many states, they would only allow you to use nicotine for 6 months, and then your access would be denied with your Medicaid. New York has been extremely generous, and so the idea that somebody is even on a nicotine maintenance seems possible in your state. And so I think that's one way to sort of reconcile the different ideas.
Yeah, good point. Thank you.
Is there anyone on an open phone that would like to throw out a question or put something in the chat box? It could even be a particular case that you're working with that you have a question about.
I have a question for the group. I'm just curious, in the audience today, are you participants that have come already to the live training? Did you come to the webinar because you heard good things about the training, or because your agency is pushing this? Or I'm just curious how people came to this today. And you're certainly welcome to put that in the chat box as well. Yeah.
Wow. Okay.
Nancy, you're good. So this is helpful, thank you, and perhaps you've had colleagues that came to our live trainings that recommended participating in some of these webinars. That's helpful feedback.
So, Jill, there's a few comments in the chat box. Dr. Ogunlesi, I'm sorry, Dr. O, I'm probably saying that wrong, is from Interfaith Medical, and they are currently working really hard to implement tobacco use disorder treatment and are looking forward to joining live training in the city once we're up again with those in the new year. So that's, she was joining in the meantime. Dr. Deepu also had participated in the state-operated Tobacco Learning Collaborative, and so joined us as a follow-up to that participation.
Terrific.
So I do see that we have just a few minutes left. I don't know if you have any concluding statements that you would like to make.
Thank you for joining us, and I hope it was helpful information. And this will be rebroadcast, or you want to say something about that? Will it be archived?
Yes, and so thank you very much for again, your expertise and your always thoughtful and really energetic presentations. I know everybody always appreciates what you have to offer, as do we, and we will archive this webinar. We'll send out information about that when it's available. It will have continuing education, and you can also download the slides from this presentation here by clicking on the title and hitting download files. So again, thank you so much for joining us, and Jill, for your, as usual, wonderful presentation. And if you haven't seen our website at the New York City TCTTAC, which the city chose the name, it's Tobacco Cessation Treatment Technical Assistance Center. There's lots of really interesting fact sheets and posters and tools and things that you can use with your staff, things that you can use with the consumers you're working with. So please go there and check it out. You can download everything for free. It's in the public domain, and reach out at any